Good morning, guys. A lot of familiar faces. Show of hands, how many pediatric dentists do we have here? Okay, quite a few. I'm just like you guys. I'm not an expert on this stuff. I'm going through it with y'all. And really, my presentation here is going to be going through the AAPD Assessment Tool for Airway. If you guys aren't aware of it, they put it out a few years ago. I think it's a really good screening tool. The entire purpose of that is for referrals. And so our piece of this puzzle, we're not doing the airway surgeries, we're not doing orthodontic surgery, we're not putting in the RPs, most of us. We're going to be the ones that are seeing these kids at a younger age, younger than the orthodontists, younger than the surgeons, about the same age as a pediatrician, but more frequently. And so what should we be looking for? What should we be aware of? And then I'm going to get into the why, because if you're like me and you went to residency over 15 years ago now, this stuff was not discussed. Airway for us was really only brought up when it applied to sedation, IV, GA, open airway, stuff like that. So my hope is that none of this is going to be rocket science, but it's stuff that you'll be able to take back with you on Monday morning when you go back into work, because if you're like me, I like just really practical things. I like easy talking points. I like things for moms and dads to be able to hear from us and for us to be able to help transition through our work day. I'm going to start out with just a little bit about myself. Why does this matter for us? We're going to go into that assessment tool. It's a 2-page thing. Are you guys familiar with the assessment tool? Yes, a little bit? Okay. So we'll go into the parts that I'm going to break it down question by question, get into why the AAPD put those questions in there. Then the practical implementation stuff. If you sleep through anything, pay attention to that part. That part's going to be important. The referrals, basically everybody else in this room that we're going to work alongside and send to. Just a little bit about myself, but that's really not as important. What I want you guys to kind of first focus on and hear about is just 2 stories that happened this week. And these are probably very similar to what you guys hear in your practices. So I'm going to start with patient A. Patient A was he's a new patient to me. Mom is a mother of 4. This child came in for referral for caries on tooth K. And this just happened on Wednesday this week. And the hygienist comes to me and says, hey, this child's got caries on tooth K. Oh, by the way, the mom said he needs an expander too, or wants you to look and see if he needs an expander. Okay, that's an interesting consultation. Let's address the caries first. We'll look at the airway stuff second. So we sit down, I get a good health history, I get a good background, and is that better now? Yes. You guys hear me better? Yeah. Okay. Get a good background, and what I found out is this child, per the mom, she's a mother of 4, definitely had his adenoids out, probably had his tonsils out. She wasn't sure if he did or didn't, because she couldn't remember which child it was. Which was fantastic. Said he used to snore and mouth breathe, but doesn't think he does now. Had a history of otitis media, history of tooth decay. So okay, got a good history. Looking there at the child, he just needs to brush better from what I can tell. But in terms of his actual dental arch, his actual relationships, he looked great. He was a mixed dentition, just getting his 6-year-old molars in. He had a good amount of space in there. He still had the leeway space between the canines and the primary and first molars. He confirmed that he had his tonsils out, which mom was like, oh, great, okay, that's my 4th child that I'm bringing to you next week. That's when I'm going to get the tonsils out. I said, okay. So then I just lead up into, why do you think your child needs an expander? Why is this coming up? She goes, well, I just have heard some things, and I think we should be looking at that. I said, well, let's look at the overall picture of your child's anatomy right now. Long, skinny neck. After I confirm this, he's not snoring or mouth breathing anymore. He has no lip incompetence. I had him do a free range of motion exercise with his tongue. He then informs me that his tongue released when he was an infant. He's got a great range of motion. He can touch almost the base of his nose, the columella. So I said, okay, kid's got a nice floor of mouth position for his tongue. And he's got space in there. He's got a nice shallow vaulted palate. I go, this child looks fantastic. Why in the world are you thinking an expander for him? You've already done all the good things. He's at a great spot. She goes, okay, yeah, I think you're right. We'll have to think about the 4-year-old when he comes in next week. Okay, great, we'll look at that one. But that's patient A. Does that sound familiar to you guys? Are you guys seeing the same stuff in your practices? You hearing the same things? Caitlin, you're nodding yes, so good. Now I'm gonna go to patient B. Patient B is a patient of mine that I've had for a little while. He had a little bit higher caries rate, slightly obese, shorter neck, 8-year-old child. And this airway stuff I'm still learning and figuring out how to put it into my practice every day. So he was at a recall and he had broke a restoration that I placed a year ago, which is not that common for me. So my first question now is your child Brux? Well, yes, he bruxes. Okay, so now I'm starting to think about some of these diagnostic tool things. Okay, if he's bruxing, what else are we looking at? Well, let's look at his tonsils. Okay, he's a 2+. All right, that's a little bit bigger. He's got a slightly larger tongue. He's got a short neck. And I said, okay, then he's snoring or mouth breathing. Yeah, he snores or mouth breathes pretty regularly. Okay. Any bedwetting? Yeah. And now the dad kind of perks up. This kid's 8. He's like, yeah, he does bedwet actually. And I've always wondered why this is an issue. So now I'm going through my through the assessment tool in my head, and I'm thinking, listen, we've got to get you over to an ENT, get you looked at for your adenoids and possibly tonsils, even though they're only a 2+. He's got a very V-shaped palate. I said, and he's definitely maxillary constricted. I said, we got to get you to an orthodontist as well. We probably need to start thinking about you seeing a speech pathologist or a myofunctional therapist because he's got some obvious lip incompetence. So that's patient B, and that patient been with me for a while. So the reason I share both of those is this is a journey. I'm still learning alongside a lot of you guys. I didn't learn this stuff in residency, but I think that tool has a place. And if we understand the why behind it, and we understand, what that tool is pushing us into, we can actually improve kids' lives. So I'm going to start a little bit about why we should do this. Obviously, we treat children, not just baby teeth. I love pediatricians, but they don't really look at cross bites. They don't really look at open bites, the majority of them. And so I think we have an opportunity, seeing them at a younger age, to be aware of those things and see where that's going to push us from an airway standpoint. Obviously, if we intercept that, we can really improve their quality of life, and we'll get into why that matters. I'm going to just briefly talk about myself. I went through an airway journey, if you want to call it that, about 9 months ago. When I was in the Navy, about 14 years ago, I was diagnosed with having a deviated septum on the right side, where I was 100% occluded, and I was 70% occluded on the left side. They said, congrats, we can go in and do a tremendoplasty and septoplasty, and we'll do it under local anesthesia. And I said, no, you will not do this under local anesthesia. This sounds absolutely terrible. And so this is Walter Reed. This is in the middle of the Afghan war. And so there was no operating room time for lowly pediatric dentists with deviated septums. They had bigger things to do. So I just suffered. I've suffered for the last 13 years with it. And then I saw a good friend of mine, Tim Kelly, who's an ENT down in Fort Mill and Rock Hill. I said, Tim, this is getting bad. And I put this slide up over a sleep number bed. But I was at a point where I was up every 2 hours, turning side to side, just trying to breathe at nighttime. I couldn't breathe through my nose at all. I was doing nasal rinses, nasal hygiene. I was using Navage, if you guys know what that is. I couldn't breathe. And I noticed my attitude was bad. Like Dr. Joy, I was probably a little bit more grouchy at work. But my poor wife is suffering. She can't sleep at all because I'm turning all the time. And the big thing I noticed, and again, this is anecdotally, but we'll get into a book called Breath that highlights this a little bit by James Nestor. But I noticed my heart rate was starting to elevate now on my Apple Watch and in my bed. I go, this is weird. This has to be related to my breathing. So that was my impetus to go and get the surgery. And lo and behold, the next 3 weeks right after the surgery, my heart rate had, was climbing up in the mid 60s, low 70s. It was right back down to the high 50s, low 60s. And so I know that having that patency now in my nose really contributed to my breathing. And so again, if we look back at this AAPD assessment tool, it's all about sleep disordered breathing and what our little piece to that puzzle is. And so I like to think of us more as kind of like primary care pediatricians in this regard. We're not so much the surgeons going in and fixing something, but we can be a really good assessor and we can be a really good referral base. Yeah, so basically I just want to get into a little bit about why this matters. The disrupted and insufficient sleep is linked to aggression, hyperactivity, and low social scores. And then overtired kids, they tend to be some of the most rambunctious and rowdy kids in our practice. I'm sure you guys are all aware of those. This graph right here I think is extremely helpful simply because it gives a nice holistic view of start to finish and where we're going with this. The underdeveloped dental arches, that doesn't just show up genetically is what I'm learning. A lot of that is functional based. And so as our society, as our culture is now post-agrarian, what we're seeing is the jaw is actually shrinking. Stanford had a really good study about that. And I had heard about that in residency, but when you look at the data, they're saying this is happening too quickly for us just to relate this simply to genetics. We actually think a lot of this is contributed by physiologic factors in our day-to-day agrarian culture, our softer foods. Now, kids are not nursing as much anymore. We've got a lot more bottle-fed kids. And so this is actually changing some of our jaw shape and our jaw dynamics. And so what's that going to do? That's going to lead to some of these underdeveloped arches and jaw shapes. That can lead into the compromised airway that Alex was talking about earlier, the maxillary constriction. It can lead to some of these other things. And so we've got to pay attention to that, because that's what's going to then feed into our sleep disorder breathing and those issues. So I think that slide's a nice holistic approach to that. This is the book I referenced. Nestor is a journalist, and he did some anecdotal stuff as well. He's a freediver. I'm a freediver. I kind of like freedivers because they pay attention to their lung volumes. They really get in tune with their bodies. And one of the things he noticed really anecdotally in his study, this is a fantastic book if you're interested in breathing and what that does and what nasal breathing's benefit is. But what he talked about was he noticed a drop in his systolic blood pressure from about 142 down to 124, just when he went from solely mouth breathing for 10 days down to nasal breathing. So you got to think, what's that going to do throughout a lifetime for a child? So if you put all these factors together, we're seeing them at 2, 3, 4, 5 years old. If we can help be a piece to that puzzle and improve that, you can really improve that child's quality of life. You can also improve the family dynamic. So this is what the tool looks like. It's got 3 different sections on the front. I'm going to kind of go through some of these questions relatively quickly, try to catch up some time here for you guys. So the first question on there is on prematurities. Premature children are 3 times more likely to develop OSA. That's an important thing, because a lot of us, when we go through our health questionnaires, we see parents check these boxes, but I don't think it necessarily highlights to us, hey, we should be thinking that OSA is going to be a higher risk factor for this child. So when you guys see your health histories, when you see that come up, just let that kind of ring a bell in your head. Another thing that I thought was important was the American Academy of Pediatricians noticed that 1 out of every 5 kids who snore may have OSA. So what that tells us is there's probably a much higher prevalence to this going on in society than we're really aware of right now. And then if you want to look at the long-term thing, like Reza had mentioned earlier, kids become adults. And so if this is left untreated, we know that sleep apnea is going to be associated with dementia and Alzheimer's. And so there's some things there, again, that should help be an impetus as to why we should be looking at this as practitioners. The next part of the assessment kind of gets into craniofacial syndromes, physical neurological impairment, low muscle tone, respiratory diseases, things like that. The reason I think the assessment tool is asking these questions is really to highlight to us as practitioners, this isn't going to be your cure-all treatment modalities for some of these patients. So if you've got a patient that has Down syndrome, let's say, their airway issues are not necessarily going to be something that we're going to go in and resolve just by attempting to try to get an expander in there or doing a tongue release. These are going to be complex issues that require a lot of time, a lot of treatment, a lot of work with our fellow colleagues. And so it still doesn't mean you shouldn't have the referral to ENT. But at the same time, kids with Down syndrome, their sleeping patterns are very different than us. This picture I put in there because this child sleeps in half, and that's a pretty common thing for children with Down syndrome. They sleep in very odd positions. They have very atypical dental arches. And so we have to be aware that when we're talking about this, it's going to vary from patient to patient. This is a very dynamic, very fluid thing. It's not going to be one-size-fits-all approach. Okay, the next part of the assessment, this gets more into your daytime indicators. These are the things that, when you go through asking the parents about this, you're going to be just asking about the child's day-to-day behavior and their day-to-day appearance. So are they a mouth breather, not just asleep but awake? Are they restless? Are they unable to sit still? Are they hyperactive? Are they waking up with headaches? Does the teacher notice that they're sleepy during the daytime? There's another, my friend Kim, who's a speech pathologist here, she kind of turned me on to this about 6 months ago, the Paris 6 scale, and I think it's got a couple of decent things. And so when I get into this portion of my assessment, there's some other questions in here that I try to feed in there as well, where I'm looking at mental and strength and things like that. And again, that's showing me, where are we at with our breathing position? Are we mouth breathing? Are we nasal breathing? So the third part of the assessment, this gets more into the sleep history portion of it. I think this was pretty instructive to myself. I didn't know some of these things. And since this assessment tool's focus is really on sleep disordered breathing, It's probably good for us to have a good baseline. If you're like me, I didn't learn this at Buffalo, but to understand what kids should be getting in terms of sleep, what their duration is, and then what that may feed into as they're growing and developing. And so the standard amount of sleep for, let's say, a 4-year-old is around 10 hours. And these are some basic, simple questions we can ask parents, and that will give us a good gauge on whether we need to be considering referring or not. One of the things that the Academy of Sleep Medicine mentioned on there that I thought was really good is that sleeping the number of recommended hours on a regular basis is associated with better health outcomes, including improved attention, behavior, learning, memory, emotional regulation, stuff like that. So these are some things that we need to be aware of the benefits of that so we can inform our parents that too. The other part of it gets into more questions about falling asleep quickly, falling asleep easily. Do they snore loudly? I'm always reminded when I ask that question of these 2 brothers I have. The mom would say, when I asked her this question, she said, yeah, he snores loudly. It sounds like a train is down the hallway. I can feel the floorboards vibrating. And I said, I think you need to go see an ear, nose, and throat doctor right now. And so I sent him down to Dr. Kelly, and they come back, and he's got grade 4 plus tonsils. You can't see anything. His tongue covers everything up. And this kid's just got the tired, droopy eyes. I mean, the first thing he needs out, Dr. Kelly sent the report back, is positive for adenotonsillar hypertrophy. And so that was him and the brother. So again, just easy things that we can do. All right, so this is part 4 of the assessment. This gets more into the clinical side of things. I think you guys are all familiar with your Mayo-Petty and your Friedman scales. One thing that I think is important is, at least me, I used to always do this with a child laying down, and you absolutely can't do that. You have to have them sitting up when you're doing this. You get a very different appreciation for the pharynx if you have the child sitting up. So when you do this in your office, make sure you do that, please. One of the questions in there just starts out with, does the patient appear overweight? And so I like this quote from an ENT down in Texas. They had just done a study, and one of the findings he said was, with the growing rates of childhood obesity, we're seeing an increasing number of pediatric patients with OSA. Our study is suggesting that higher levels of obesity and advancing age are key contributors to this issue, and that efforts to address childhood obesity can have a positive impact in improving sleep quality, reducing adverse effects of OSA and residual OSA. Out of the Journal of Pediatrics, which I've got off to the side here, another thing I found was really interesting is that they're starting to see, Alex, I think I mentioned about causation not always being correlation, or correlate, that's what you said, right? Yeah, or correlation not always being causation. This was a really fascinating study they did where they found there was an increased odds of obesity in kids associated with early sleep disorder breathing symptoms, and separately, independently, with short sleep duration around ages 5 or 6. And the level of association was the same. So whether your child had too little sleep or whether your child had sleep disorder breathing symptoms didn't matter. The symptoms that showed up were equal. And as that study went further down, I've got the quote here. It said, the prior 2 studies had suggested that sleep disorder breathing in early life could actually promote overweightness in later life, particularly among those children who have already an initial proclivity of predisposition to being overweight. And so that was a study that was one of those 2 studies was out of the UK, but I thought that was fascinating to realize that poor sleep quality, and poor sleep duration can actually lead to childhood obesity. And so that's something, again, when we think about our why, that should be included in there. Then the 4th part of the assessment, as I said, it was more about clinical evaluation. So this is when you get into your limited neck mobility, your retrognathia, things of this nature. I try to just list up here where my brain goes with these things. And so if I see limited neck mobility, I want to figure out what's going on. Is this a really obese child? Do they have those typical fat rolls in the back where they can't get their chin hyper elevated? Do they have scoliosis? I had one mom where we couldn't get this child to lift her chin up. And I said, does she have scoliosis? And she goes, I think she might. And then she came back, and 6 months later she goes, hey, we actually looked into that. I had her in a bathing suit. I noticed her neck kind of did this. I was like, yeah, well, you need to get this looked at. So anytime you see those things, let that be a trigger point for you to explore a little bit more. If we see retrognathia, I want to be sending off for a CBCT with either my ortho friends for eval for Herbst appliance or something along those lines. If there's limited oral opening, I'm going to send this off to OMFS or the orthodontist. Lip incompetence, I think myofunctional therapists, speech pathologists. They have a lot to offer us in way of that, and it's an emerging field for us to collaborate with. Anterior open bites, obviously you want to figure out the root cause of that. Is the habit appliance involved with that? Is this a non-nutritive sucking habit? I kind of skipped over this slide earlier, but for those of you who talk to parents and counsel parents about pacifiers, there's those more orthodontic inclined ones that have the slope versus those Tommy Tippy big ones they get from the hospital. The more you look at the studies on it, there actually is a benefit to those physiologic style pacifiers. They actually can improve the decrease in overbite and open bite, So that's one of the things that when you talk to parents, you may want to bring those things up. Narrow maxillary arches, vaulted palates is on there. Obviously looking at RPE valve and ortho makes sense, same with cross bites and the macroglossia. So here's the practical implementation. So if you slept through the rest of this is where you want to focus. For my oral evals under 3, I'm looking at frenums. If they're an infant coming in for a tongue or lip tie, the airway for me kind of slides in with that suck, swallow, breathe, regulated breathing pattern. Sometimes the mothers will come in and say, hey, they're nursing. As I'm trying to nurse, I'm noticing the child's getting milk spillage. They're struggling, they're gurgling in between swallowing and trying to take a breath. And so those are one of the things I'm going to look at for my infants. For the other kids under 3, just evaluating mouth breathing or snoring. Non-nutritive sucking habits, like I said, I've got a picture of those physiological pacifiers right there, and there's some data out there that have shown that they do reduce the occurrence of anterior open bite. And so the interesting thing is, anytime I recommend a parent to get rid of the hospital grade silicone green ones on the right, to switch over to the comfortable ones, they always come back and say, my kid wouldn't do it. He spit it out. He didn't like it. So unfortunately, the hospitals are getting the kids these ones that are causing all these open bites that are much too young of an age for us. But if you can, try to overcome that in your practice. And then this is what I do at my periodic comprehensive oral evals. I try to really get my staff involved in this. We're only going to spend 1 to 5 minutes maybe with these patients. And so let's be realistic. We can't spend our whole visit talking airway, but what we can do is like that child who broke that filling, we can pay attention. And let that kind of be a guide or something to make us think about these things. So I by no means do this with every single patient. I let the situations kind of guide me. But again, if we get back to our health history, be alert if it's a preemie, they have obesity, things of that nature. Start being on the lookout for OSA and where you may want to refer the child out. With OHI, I think it's important just to talk about the open mouth posture, the caries rate, the mouth breathing, just the heavy amount of plaque, and just really stressing good hygiene in those cases. And then with dietary counseling, as I talked about earlier with the smaller jaws, one of the interesting points in there is that processed foods we think is leading to that. So just another reason for us to tell parents, try to limit the processed food.
Okay.
Go ahead.
How often do you guide parents or families like that taping to guide them?
Great question. I get that probably once a month, not as much as you'd think.
Sorry, can you repeat the question?
Yep. So the question was, how often do I get parents asking about mouth or lip taping? I get that probably once a month. And what I simply say to parents is this. Your airway has 2 passages to inhale and to inspire air, so through your nose and through your mouth. Are you 100% confident your child doesn't have, hypertrophic adenoids? And the parents usually say, no, I'm not confident. I say, okay, I don't want to put tape over the mouth in case they do and they can't and they obstruct. It seems to be a big fad that I'm seeing that parents are coming in. I always ask, where did you hear about this? It's almost always from some sort of algorithm. I'm not saying there's not benefits to trying to get some sort of nasal breathing. I'm not sure that's the best way to go about it. So usually what I say to them in those cases, after I get through that first part, is I say, let's look at the overall airway of the child. Let's understand why this is a concern, and then figure out where we can go from there. Does that answer your question?
Thank you.
Yep, you're welcome. Okay, so this is the modified Mallampati posture, the Friedman tongue posture. They're both fairly similar. This just helps me while a child's sitting upright so we get a good chance to evaluate the airway. Obviously, the further you go on the scale, the more we're going to have issues. All right, so practical implementation. I was talking to somebody last night about airway and sedation. Back when I trained, that's about all that airway mattered for us. It was just, what are you looking at with your sedations? Obviously, that still matters. If you're a Mallampati 3 or 4, you really probably should not be doing oral sedation in those cases. If you're going to do an open airway technique, make sure you're talking to your anesthesiologist about that prior to letting that patient show up the first day. And then even in those cases, you may still need to get the tonsils out before you do that. There's been a numerous number of cases I've had for in-office IV that we've just punted out 3 to 6 months to go get the tonsils taken care of first. So just to kind of finish up here, I think it's really important that we realize that collaboration is what's going to create outcomes here. If you guys have never worked with a myofunctional therapist or a speech pathologist, I think this is a great place to meet some and get to know what they do, what they can teach us. You know, there's certain reflexes that kids have. I'm going to pick on nursing infants right now, but there's certain reflexes they have when a lactation consultant or a speech therapist goes in and uses their finger to try to manipulate the tongue to move certain ways, and the kids have certain reflexes, and that can tip them off to certain things. There's stuff that we can learn from our colleagues that we don't know, and so I think it's really, really helpful to just collaborate and listen and learn. All right, and then referrals. So this is kind of my pocket of people from certain age groups. So again, it's a team approach. From 0 to 3, lactation consultants, myofunctional therapists, speech, ENT. 4 to 7s, I'm looking more at ENT, speech, myo. And then 7 to 12, that's really when I'm going to get more of my orthodontic buddies involved, oral surgery, things of that nature. Yeah, encourage communication from your parents. Try to get feedback. You know, it's not a one-size-fits-all approach, but do your best to just keep helping your patients along. I think when you can incorporate this tool into your practice, like I said, just in a 1 to 5 minute session, if you can just make those referrals, get the kids where they're supposed to go, and pick up on those things, the parents come back extremely, extremely receptive and thankful. So that's all I have. Questions?